Hello, I'm Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club. In today's special ASCO 2021 episode, Craig Underhill talks to Gilberto Lopes and Mel Moore about all things lung cancer. It's a thorough and entertaining discussion covering practice-changing developments and controversial trials. As ever, you'll find full biographies, Twitter handles, and all the links to the papers discussed in the notes on our website. For regular news and podcast updates, subscribe to the Oncology newsletter on oncologynews.com.au. It's free and it's a great way to support the OJC. This is Rachel Babin and this is the Oncology Podcast.
G'day. It's a great pleasure to welcome two superstars of thoracic oncology to our Oncology Journal Club podcast special on ASCO lung cancer. So firstly, Gilberto Lopes, who is the chief of the medical oncology service at the Sylvester Comprehensive Cancer Center at the University of Miami. He's also editor-in-chief of JCO Global Oncology, originally from Brazil, now forging his career in the US, the most tweeted person at the ASCO 2021 meeting, apparently. Welcome to the podcast, Gilberto, and thanks for coming on.
I would say that's a dubious claim for fame, but hello everybody. It's a pleasure to be with you here down under.
Fantastic. And one of the key opinion leaders, certainly in Australia, is Melissa Moore, medical oncologist from St Vincent's Hospital in Melbourne. She's a board member of the Thoracic Oncology Group of Australia. I noticed on her Twitter bio that she follows the Sydney Swans. I'm not sure how many friends she's going to win by stating that, but nevertheless, she's a lovely person. Thanks for coming on, Mel.
Thanks, Craig, for the invitation. And no, down here in Melbourne, not many compatriots cheering for the Sydney Swans, unfortunately.
No, you should keep that a secret if you're working in Melbourne, I think.
Loud and proud, Craig.
This is the Aussie rules, Gilberto.
Aussie rules football.
Yeah.
Take you to a game if you're down here again, Gilberto.
I used to play rugby as a teenager, so it's been a while.
Oh, brilliant.
Wow. I thought that you'd be a round ball football player coming from...
That probably have to be too good to play football in Brazil. My dad played professionally back in the day, but this was in the 60s.
Yeah, good on you. All right, well, let's get into it. It was a good ASCO for lung cancer, I think. There was a couple of new things, but also things that probably helping us a little bit trying to sort out what the standard of care is. So firstly, in advanced lung cancer, Gilberto, if you just want to outline for us, there was a couple of studies we wanted to touch on, the Checkmate 227 and the Checkmate 9LA4.
Absolutely. So let me start with 9LA4 because that's the one I really don't know how to place in clinic today. So that's always a good way to start. This is the study that Martin Rack presented. It's very interesting and very nicely designed. Patients with advanced non-small cell lung cancer who did not have sensitizing EGFR mutations or ALK alterations, as in all of the new immunotherapy trials we're seeing, were randomized to receive chemotherapy, and optional pemetrexed maintenance was allowed. And in the study arm, patients also got nivolumab and ipilimumab, and they only got the chemotherapy for 2 cycles. And here they're using the 1 milligram per kilogram dose of EP every 6 weeks, which is a lot easier to tolerate than the dose that we used to use in melanoma, or that we still use in melanoma as a single agent at least. And we had seen the results of this trial already, and out of a little bit more than 700 patients randomized, we saw median survivals improving from 11 months in the chemo arm to 15.8 months with the nivo plus EP plus 2 cycles of chemo. And there's a few interesting takes for me for this study. On the update at 24 months, we had 26% versus 38% of patients alive, and this is the overall survival data that was updated at ASCO. And toxicity, we didn't see anything new in terms of toxicity. The other update was on progression-free survival and duration of response. At 2 years, 34% versus 12% of patients had their response at 2 years. And for the PFS, at 2 years, 20% of patients had not progressed versus 8% for nivo EP versus chemo. So these results are pretty in line with what we have seen in other trials. You can get up to 20 months or 21 months in Keynote 189 with pembrolizumab plus chemotherapy. But in general, and of course, we always have to take these cross-trial comparisons with a grain of salt because of differences in populations and so on. But in general, we see that these are all in the same ballpark. So not taking PD-L1 in consideration or imagining patients with PD-L1 less than 50%, we do have very similar results for chemotherapy plus pembrolizumab, for chemotherapy plus atezolizumab, or for just 2 cycles of chemotherapy plus EP and Nivo, as we saw in 9LA. So I really don't have much. And as an aside, we had one patient today that we might think of using this regimen. It has been approved in the US, so it's not an issue for us. But I have trouble thinking of who are the patients that might get 2 cycles of chemo, but not 4. And I guess you might have the occasional patient that develops toxicity with chemo. Around the first or second cycle, you feel relatively comfortable about continuing the EP-Nivo alone, if that's the case. But I guess most of us would feel comfortable continuing just pemetrexed and pembrolizumab or just immunotherapy if that was the case. So it's an interesting trial. But as this was the latest of a series of trials showing that we could improve on chemotherapy by adding immunotherapy in one way or another, it really didn't get to become very popular, at least not in the United States.
The other thing I'd just say about the 9LA data that was presented that I found interesting was it seemed that those patients that had to discontinue due to toxicity still got ongoing benefit. And I know anecdotally, some of my patients that have been involved in 227, not this trial obviously, but still dual immunotherapy, that if they stop due to toxicity, you're worried about, or even stopping during because of resist progression, they're still 2-3 years down the track and have relatively controlled disease. So I think there's something to be said there for the ongoing immune surveillance despite not being able to complete the full course of treatment.
Absolutely. And that is something that we take in consideration as well. Somebody that develops severe toxicity and we need to stop. In the past, we kind of wanted to restart immunotherapy right away so these patients were better. And now with some data coming out of the 2-year data out of pembrolizumab, we feel a little bit more comfortable stopping and just restarting if we need to. So that's an interesting observation indeed.
Although just on that topic, there was a paper at this meeting that looked at response and association with survival. And in fact, it was the patients that got grade 1 and 2 toxicity seemed to do the best. So the 3s and 4s obviously stopped early and maybe didn't do as well, or maybe, were sick from the toxicity. But sort of that balance, isn't it? You want to see a little bit of toxicity, but not too severe.
That was a very intriguing analysis. That was the IMpower trial joint analysis that Mark Sosinski presented. And the interesting thing is that the patients who didn't get immunotherapy, if they had immune-related adverse events, which I didn't quite understand how those came to being, I guess it's the type of event. And I guess that these were placebo-controlled, so you didn't know if the patient was getting immunotherapy or not, so they got reported as immune-related events. Those patients who didn't get immunotherapy but had, quote-unquote, immune-related adverse events did better as well. So it's an interesting finding, and it's curious.
It is.
I must say, I spent that entire presentation wondering, was I missing something with the immune-related adverse events in the non-immune therapy arm? But yeah, it was very interesting data, and it's sort of analogous to what we see in the colorectal cancer population and cetuximab side effects. So watch this space, I think.
So let's switch just to 227. So different design in same essential population of patients.
Part of the trial for PD-L1 positive patients, 1% or more, and then you had part of the trial that was for those that expressed PD-L1 at less than 1%, and then patients could get Nivo-EP versus chemo versus Nivo, or Nivo-EP plus chemo versus Nivo-chemo. And the update at ASCO this year was the 4-year overall survival for those patients with expression of 1% or greater, and we keep seeing that patients who receive Nivo-EP do better than those that receive chemotherapy, with numbers that are very similar to what we just quoted for 9LA. So at 48 months now, patients who received Nivo and EP had a 29% survival in this 4-year mark versus 18% for patients on chemo. And they did show us results for non-squamous and for squamous, and those data look a little bit better for non-squamous, 32 versus 23. And for squamous, 20 versus about 6%. So patients who do receive Nivo and EP without a chemotherapy backbone also do better than patients who receive chemo. And this is a very interesting regimen for those patients who do not want to do chemotherapy. From the update at this year, I mentioned the overall survival. They also showed the overall survival for patients with PD-L1 of 50% or greater. And for these patients at 48 months, 37% of patients were alive in nivo-ipi versus 20 in chemo. It's interesting that we start seeing plateaus even for the patients who were in the trial, which probably means that they got immunotherapy after the trial, and that's why you're seeing a plateau that we didn't used to see in trials before immunotherapy became available. What else did they present that was interesting? They also presented update on overall survival for patients with PD-L1 of less than 1%, and this for us is a little unusual or interesting, but maybe we can't act on this in the US because ipi and nivo were approved here for patients who expressed at least 1% of PD-L1. And at 4 years, 48 months, 24% of patients on nivo-ipi were alive versus 10% of patients on chemo. Non-squamous, that was 25 versus 12, and squamous, it was 22 versus 5. So people are now asking, is this a regimen we should use for patients on squamous cell who have a squamous cell non-small cell lung cancer and express less than 1% PD-L1? So this is kind of the niche that people are starting to look into. When we really get to the number of patients in the trial at that point, we're talking about 10 to 20 patients per arm. So it's a little hard for us to make a categorical decision in that manner, but that's what some people have been discussing. I don't know what you think, Mel.
Look, we don't have this available to us in Australia, Gilberto. My site took part in this study, and I guess I'd just remind our younger listeners that this was a study that came about before we had routine PD-L1 expression. So we were relying on sending tissue centrally to get that result. So you really were explaining a 6-arm trial to patients. So it was a big ask. Look, I think it's attractive to be able to avoid chemotherapy. So I'm somewhat disappointed that we don't have access to this. And certainly the patients that I treated on this regimen tolerated the nivolumab and the ipilimumab well. I guess what we need to say about both the studies that we've discussed so far is that because this field is moving so quickly, is that it's not compared to the current standard, which is either monotherapy, especially in the greater than 50% PD-L1, or the chemo pembro in the negatives and the less than 50%. So it's hard to make comparisons without that standard arm. I note that in this study there is a nivo alone arm for the PD-L1 less than 1%, or in both sections actually, both PD-L1 expressing tumours. But the study wasn't powered to look at nivo-ipi versus nivo, so I don't think we can read a lot into that sort of data.
Well, in fact, they haven't reported all of that data, have they, the comparison? So that's one of the flaws in the reporting of this so far, and one of the controversies. So we'll come back to talk about, can we work out the standard of care or not? Just briefly, let's look at the pooled analysis from the FDA for the PD-L1 1 to 49%, because that's a common population of patients, right? We often see the low PD-L1s, or, probably in working practice. So what did that analysis show, Gilberto?
So this is an interesting study. The FDA now has taken a much more active stance in actually aggregating data that they use for approval and using that to try to generate new insights. So it was really interesting to see Dr. Akimboro's presentation at ASCO. And what they were looking into is that in the US, we have single-agent immunotherapy checkpoint inhibitors approved for those patients that have PD-L1 of 50% or above. And we have single-agent or combinations approved for those patients that have expression of between 1 and 49. And this is an extremely interesting point, because in a lot of our trials, we really don't know for sure if what drove the benefit was the patients above 50%. And is it safe for us to use immunotherapy alone for those patients that express between 1 and 49? And that's something that in practice we really don't do. It's very rare that we use immunotherapy alone, at least as a single agent PD-1 or PD-L1 inhibitor. We would usually prefer using chemo plus immunotherapy. So they actually set up to take a look at the combined data and see if they could tease out and tell us if there were any differences in overall survival and progression-free survival. Of course, all these patients did not have EGFR or ALK alterations, and they used the usual definitions for PD-L1 expression, and the statistical methods was pretty adequate in what we would expect for such an analysis. And they put together Keynote 42, which was pembrolizumab as a single agent, Checkmate 227, which is a combination of immunotherapy, And then the combined chemoimmunotherapy trials were Keynote 189 for 07 and 21, Empower 150 and 130, and CA 2099 LA, which actually had Nivo and IPI, just as we discussed a few minutes ago. And they got about 639, exactly, actually not about, patients in the IO arm and 529 in the IO only. And the comparison results are what we might expect. IO only, we saw a median survival of 14.5 months, and chemo IO, that number reached 21.4 months. That hazard ratio will be 0.68, and it did not include one, so this is a statistically significant result as well. The curves are pretty separate from the beginning. So this does confirm our bias that for patients between 1 and 49, we should strive to try to use chemotherapy plus immunotherapy. They had similar results for progression-free survival, hazard ratio 0.6, the medians were 4.2 and 7.7. And I think that this is an important message because in trials where we do see a benefit for immunotherapy as a single agent, there's usually a crisscrossing of the curves. And there's a moment in the beginning, in the first few months, when immunotherapy actually seems to be worse. And I think that using chemo abrogates that phenomenon.
Now, did we see the same in this trial? Was there at the start of the curve, did the immunotherapy patients do worse?
This actually, they did worse throughout. So here they did worse for PFS and OS from the beginning. The patients getting chemo and IO, and we have to remember that in the trials, the comparator arm was chemo alone, not chemo and IO. So in this indirect analysis of chemo IO versus IO, chemo IO certainly did better in the 1 to 49. It's important to mention that a few studies have looked at the same question for patients with expression of 50% or greater, and there we don't seem to see a difference in overall survival. We do see differences in progression-free survival and in response rates in a number of meta-analyses that have been published, including one that we did. But in terms of overall survival, we really don't see a benefit of adding chemo for patients with PD-L1 of 50% or above. And Mel was asking if in any group we didn't see, we saw if any groups could actually get immunotherapy alone. And patients above the age of 75 or 75 and above did seem to do about the same. They did worse than younger patients with median survivals of about 10.3 for IO only and 13.9 for chemo IO. So even there, if a patient can tolerate chemo, I would still try to do that. And that's what I remember in looking at the slides that I remember was significant.
Yep. So if we break it down into some categories now, like what our options are for standard of care based on all this data and this update from the 1 to 49. So in elderly patients, if their performance score is okay, does that alter what you do?
If patients have a good performance status, I would usually still try to do chemo and immunotherapy. And I usually use single agent PD-1 inhibitors and not CTLA-4 plus PD-1 or PD-L1.
So for the PD-1 high, we now have a choice of single agent IO or combination chemo IO. Is that correct?
That is correct. Just to mention that in the US, we actually have 3 of them approved now. We have atezolizumab, we have cemiplimab, and we have pembrolizumab. So we have a lot of options. Unfortunately, they all cost about the same. We would hope to see some competition, but we don't quite see it yet.
So, Craig, as you know, our options here in Australia are chemo, pembrolizumab or pembrolizumab monotherapy. I must say in a lot of my patients with greater than 50% PD-L1 expression, I'm still using monotherapy, and I think that differs around different centres. Certainly if someone has high disease burden or is very young and fit, I'd probably lean towards dual therapy. But I think the data from monotherapy was very compelling in the more than 50% PD-L1 expression. And if people can avoid chemotherapy and its toxicity, I think that's a great thing.
Yep, that's pretty much what we do here as well. And now for the 1 to 49s, has this pooled analysis changed things? Would it tip you towards doing the combo rather than single agent, Mel?
I've been using the combo anyway, Craig. I haven't really felt comfortable with monotherapy in this group. And I guess, look, for a more elderly or a frail patient, you may consider it. It certainly didn't seem worse than chemotherapy in the Keynote 042 and 024. But and this would just really reinforce my desire to give dual therapy in this particular subset of patients.
Yep. And then for the PDL0, it's and no other actionable mutation. It's pretty much combination. It's pretty clear now.
Yeah, and I think our choice here in Australia now is the chemo pembro, or we do have 9LA regimen available to us, so chemo 2 cycles and ipi-nivo. And to be honest, I haven't used the 9LA regimen in the context of just normal clinical practice as yet, but it's nice to have options.
And Gilberto, in those low PD-L1, do you use ipi-nivo plus chemo?
So 1 to 49, we most often use chemotherapy plus one agent, and pembrolizumab is most commonly used, but some people do use atezolizumab. We do have a few colleagues that use 9LA, but it's definitely a minority.
Okay. And squamous, is that different, or do you just treat them the same?
Except for the pemetrexed backbone not being used, I pretty much treat the same. Now some people are making the argument, but I think that the number of patients is too small for us to make an argument that ipi plus nivo would be of benefit. So I think the jury is still out there.
Fantastic. So it's great discussion. Thank you very much, both of you. Let's switch track. We'll go back a step now to the locally advanced lung cancer and maybe look at the 5-year results of Pacific. So this is something, again, that we have available in Australia now for some time with durvalumab. Mel, do you want to just quickly outline the results of this study?
So we know that Pacific was a study for unresectable stage 3 non-small cell lung cancer patients. Patients had their standard chemoradiotherapy, and for those patients that hadn't progressed, they were randomized to either placebo for 12 months or durvalumab every 2 weeks for 12 months. And there have been previous high-level publications showing a survival benefit for the patients in the durvalumab arm. And this presentation was the updated 5-year survival and remains impressive. So at the 5-year mark, the updated overall survival was 42.9% in the durvalumab versus 33.4% in the placebo arm, leading to a hazard ratio of 0.72 with a significant confidence interval and p-value. So look, not groundbreaking new data, but certainly very reassuring to get this update that there does seem to be a little plateauing of the curve there, and hopefully we're seeing ongoing longer-term survival for this high-risk population that, look, really previously, when we're speaking to these patients, we speak about treating them with curative intent, but we know that the risk of relapse is still very high. So it's great to be able to offer something else.
I think we always used to say sort of 25-30% chance of long-term survival. Is that correct? And now this would suggest we've leapt up a little bit in that.
Definitely leapt up in the durvalumab arm, and I guess even the control arm is performing relatively well, which really makes that hazard ratio even more impressive.
Yeah. Just a practice tip, Gilberto. I've seen a few patients getting pneumonitis, and I just wonder, that's one of the risks of this regimen. And I just wonder, sometimes in the study they were allowed to, and on our prescribing system in Australia, you're allowed to have a significant gap between the end of the chemoradiotherapy and starting. In practical terms, when do you start the durvalumab? Is it straight after the radiotherapy, or do you wait a bit?
So one of the subgroup analysis when Pacific was initially presented suggested that those that started immunotherapy within 2 weeks of the end of chemoradiation did better. So we tried to start as soon as possible. I haven't seen data confirming that in the update, so I'm going to take a look at the updated publications to see if there's anything new in that regard, but I don't remember seeing those numbers again. So we tried to start within 2 to 3 weeks of finishing chemoradiation, as long as patients don't have symptoms. Often we'll do a chest x-ray, make sure there's no infiltrates that we would worry about pneumonitis. So I was surprised positively that the rates of pneumonitis were way less than I expected they would be in Pacific, and that has been a great finding.
Yep. And Mel, the same with you, just get straight on to the durvalumab when they finish the treatment?
Yeah, I do, Craig. I think getting started as soon as possible is ideal, especially in light of the data that Gilberto just mentioned. It depends on the patient. It depends how they've pulled up after treatment, and do they need a bit of a break before getting into 12 months of adjuvant durvalumab, but try to start as soon as possible.
Yeah, great. Thank you. Now, if we go back another step now, adjuvant. So this was one of the controversies of the meeting. Gilberto, do you want to lead off and telling us a little bit about Empower 010, the adjuvant study?
Absolutely. So this is the study we were all waiting for ASCO 2021. We had a press release a couple months before the meeting that let us know that the disease-free survival data was positive, and we were expecting to see how positive, what the degree, what the hazard ratio was, et cetera, et cetera. So IMpower 010 is a phase 3 trial. Patients with resected stage 1B to 3A non-small cell lung cancer were eligible. They would receive adjuvant chemotherapy before going on an immunotherapy. And this is hoping to build on what we know in terms of the benefit of adjuvant chemotherapy. Patients could receive cisplatin with either pemetrexed, gemcitabine, docetaxel, or vinorelbine, and about 1,000 patients were randomized to receive either best supportive care after that or atezolizumab, 1,200 milligrams every 3 days as the usual doses for a total of 16 cycles. And stratification factors included male versus female, the stage, histology, PD-L1 expression, and primary endpoint was disease-free survival. And this is the stickiest point, if that word even exists, when we go for the discussion, because disease-free survival, if it correlates with overall survival, it is an extremely important endpoint. It is an endpoint that is quicker to reach than it would be with overall survival, but it's not necessarily always translate, especially when we see things like targeted agents, EGFR tyrosine kinase inhibitors, and ALK tyrosine kinase inhibitors. Even though with osimertinib, we have seen data in DFS that has led to the approval in the adjuvant setting in the US, when we look at the erlotinib and gefitinib trials that have enough follow-up, that has not translated into an overall survival benefit. So does immunotherapy behave like that? Or is immunotherapy different? And as in trials with chemotherapy, in which DFS correlates with OS, are we going to see that or not with immunotherapy? That's the big, big question. But of course, if we do have a high enough benefit, a large enough benefit, even with DFS, many of us would think that this is something that we should incorporate. And I certainly would not be surprised if the FDA approves this for adjuvant use in the US in a few months. The statistical analysis plan is something that we have started to see more often in immunotherapy trials. It's a hierarchically organized with 3 primary analysis populations. So first, you do an analysis for disease-free survival in the 1% stage 2 to 3A population. Then if that's positive, you do an all randomized stage 2 to 3A. And then if that's positive, you do for the 1B to 3A. And then if that's positive, that's when you get to do the analysis for overall survival. So it does make it a little harder and longer for us to get to the final definitive endpoint. Baseline characteristics were similar in both patients, and for the PD-L1 1% or greater stage 2 to 3A population, which was the primary endpoint that was presented at the meeting, we saw that the median disease-free survival was not reached in the atezolizumab group versus 35.3 months in best supportive care, which is usually what we see in trials around the world in adjuvant setting. And the hazard ratio is 0.66. So that is a positive enough, it's a large enough effect that we would consider clinically significant as well. P-value was 0.04. 95% confidence interval was 0.5 to 0.88. When we look at the 36-month data point, 48.2% of patients were alive and disease-free in the chemotherapy arm versus 60%. So it's a 12% or so difference, absolute difference in disease-free survival at 3 years. So this is clinically significant, but who truly were the patients who benefited? And when we look at the subgroup analysis, we do see that patients that had a PD-L1 that was higher were patients that actually had a larger benefit. We see that the hazard ratio for those with 50% or greater was 0.43, and for those with PD-L1 less than 1%, it was 0.97, suggesting that there was no benefit without PD-L1 expression, and that those with PD-L1 of 1% or above, the hazard ratio is 0.66. But we always have the doubt, is that being driven by those that were 50% or above, or is that truly what you see for those between 1 and 49? So if you ask me today, I think that there's a clear benefit for those with 50% and above, and I would not be surprised or upset for an approval based on these numbers alone. For those between 1 and 49, I would love to see more data to see if that degree of benefit, if that size of benefit in DFS is enough for us to suggest approval or not. If you ask me what's going to happen, I think it will be approved for the whole
Wow. Okay.
population of the study in the US, because that's what the FDA has done with drugs recently. The DFS, disease-free survival, was the primary endpoint, so they go by what the primary endpoint is, at least while we wait for overall survival data. So this is an extremely interesting study. It's proof of concept that at least some patients clearly have a benefit from using adjuvant immunotherapy.
Mel, this is a real change. Like we were always taught and we always told our juniors that you needed to wait for the survival data. So now we've seen it last year we saw with the adjuvant osimertinib with Adura, a big controversy, and there's still publications coming out with debates about that. At this meeting, there was Olympia, which was a BRCA-mutated breast cancer and adjuvant PARP inhibitor. Similar, big benefit, disease-free survival. Everyone's saying that's could be the standard of care. We saw it in renal cancer with adjuvant IO, post-nephrectomy. Disease-free survival, no overall survival data yet. People advocating for that. So this is a real change. And your thoughts, Mel? It's
Yeah, I think I agree, Craig. It is a change, and I think we're going to have to change the way we're looking at these endpoints. I mean, clearly very big trials are being designed with DFS as the primary endpoint, so we can't help that unless we're actually inside that process. But I think it's going to be hard to show an overall survival benefit, or harder, because most of the patients in the best supportive care arm of this study will go on to get immune therapy at relapse. I think overall survival is easier to determine when patients don't have many options post the drug that you're investigating. And I guess the other way to look at it is from a patient point of view. I think any drug that can clinically delay the time to developing symptoms from metastatic disease, I suspect if you ask most patients, they would take that. If they can have a longer period of time being well, being able to live a relatively normal life without metastatic disease, that is probably a key endpoint for them. I guess the caveats to that are these sort of trials are not picking up time of symptom occurrence. They're picking up time of a spot showing up on a scan, which may have been asymptomatic still for some time. So we don't know whether picking up metastatic disease earlier is any better. Look, I would agree with Gilberto that it's quite compelling in the high PD-L1 subgroup, hazard ratio of 0.43. I think it would change my practice. I think if it was funded in Australia, and that's the other question here, I think you'd be hard pressed not to have a discussion with patients about the benefits. And that's the other thing, having discussions with patients about endpoints is challenging. I think there's probably some endpoints that as oncologists we find puzzling, let alone as a layperson patient. But I think this is an exciting study, as is immunotherapy in the neoadjuvant arm. I think that's even more exciting. So I would hope that this gets consideration in Australia, particularly for the high PD-L1 population.
I think you're right. The thing that worries me is that life-changing toxicity that can occur in some small number of patients. So there's this big debate going on in Australia, Gilberto. We have a really low rate of coronavirus, right? And there's more people in hospital with clots from the AstraZeneca vaccine, and 2 people have died in the last month of clots. It's more than the deaths from COVID, right? And so it's in some ways, as an analogy here, like for the whole population, there's a benefit, but you can get catastrophic outcomes for individuals, which is, hard to predict and can be not reversible. So, if you trigger myositis or,
without a doubt. And the word of caution in this study is that when we look at toxicity, we had 495 patients in each arm, and there were 8 deaths that were related to the adverse events in the atezolizumab group versus 3 in the best supportive care. So, of course, we need to wait and see how that's going to pan out in overall survival. But the curves look exactly the same when all intent to treat patients are included. And we see a small separation of curves for those patients with PD-L1 greater than 1%, with a hazard ratio of 0.77. Of course, this is not mature by any means, but we will need to wait and see if that's truly going to translate. Of course, we would need to wait so many years that we have a large number of patients that would not benefit from using it if we would wait for overall survival. So it is a very interesting dilemma, because there's pros for both positions. We just need to make decisions as societies, as physicians, and as patients as to what is it that we're going to value and what is it that we're going to use to make a decision.
Fantastic. So look, we're running out of time, but we're going to direct people to a couple of links to some of the abstracts. We've got the CodeBreak 100, which is the KRAS P12C mutated tumors. That's significant populations, about 8% of lung cancer. And so a new molecule to use there, available in Australia at the moment on study, but not freely available. I think, has it been approved in the US now, Gilberto?
Extremely exciting. It was approved about 2 weeks ago, so we are now ordering it for a few of our patients, and we are very excited with the results. We haven't had any approved drugs or any active drugs in KRAS mutant lung cancer or any other malignancies. I don't know, I'm old enough to remember the farnesyltransferase inhibitor trials that were negative about 20 plus years ago. They are kind of making a comeback now for HRAS mutant tumors, but we can talk about that on another day. But this is extremely exciting. The response rates are not osimertinib good in EGFR. They're not alectinib good in ALK, but they are gefitinib and erlotinib good in EGFR or crizotinib good in ALK. So we kind of get jaded very quickly, and we look at a drug like this and think, oh, this is not that good. I mean, the response rate is very decent, but we're not seeing the durations of response or progression-free survival that we see with current generation EGFR ALK inhibitors. So we kind of got jaded very quickly. But this is an amazing new opportunity for patients with KRAS mutations. Unfortunately, it doesn't seem to translate to other malignancies. We're hoping that the data for colon or pancreas, in which KRAS G12C is less common than in lung, would be more interesting. And unfortunately, we do see responses, but not as many. This is a cysteine inhibitor, so it's not a tyrosine kinase inhibitor. It's an inhibitor, but it binds to the cysteine molecule. That's why it works for those mutations that have a cysteine residue, but not others. And we have a long way to go, but this is certainly a very welcome addition to what we can do.
Yeah, fantastic. Just before we go, I did want to touch on the disparity. There's a couple of publications on disparity. And so just a reminder, I guess, that in all these discussions about all these new molecules and PD-L1, that our existing armamentarium is not always available in all the populations geographically or socioeconomically. So some sobering reminders. And while we've got Gilberto, he's the editor of the JCO Global Oncology. There's a real need for us to get NGS into routine care and to get access to some of these drugs more broadly. Final comment, Gilberto.
Without a doubt, access is one of the biggest issues we deal with. Even in the U.S., we do have centers. For instance, we have a county hospital. The U.S. in general does not have universal healthcare coverage, but Miami-Dade County does. We have a county tax that actually funds the Public Health Trust, which provides care for anybody who's been physically in Miami-Dade County for more than 3 to 6 months, depending on certain criteria. And then if you do get sick and you get to the county hospital, and then you can actually get care. That does not happen in a number of places in the U.S., but in our county, we are lucky that our political leadership saw that as an important thing to do. So our patients, even if they don't have coverage by private insurance or other public sources, they can get care. But because it is a very limited fund, we really can't do everything that we do in other places in the U.S. So, for instance, I can't use immunotherapy for small cell lung cancer combined with chemotherapy because that was not cost effective in our setting. And that may be one of the very few and unusual situations within the U.S. where we do use or somebody uses cost effectiveness analysis for this type of decision. But of course, the problem is even bigger when we go to low and middle income countries, and we have a lot of work to make even the WHO essential medicines list for cancer available in most places. We have a goal in 2025 that I don't think we will reach, which is to have access to more than 85% of these essential technologies. And we certainly have a lot of work to do.
Fantastic. Mel, any final comments? What was your highlight? The lung?
I think my highlight was actually CodeBreak Craig, which Gilberto has already elaborated on. I guess my final comment would be just on availability of mutation testing, and put a plug in for the TOGA aspiration study, which is looking to perform comprehensive genomic sequencing on newly diagnosed metastatic lung cancer patients. There's a number of sites open, but patients can also be consented remotely via the Garvan, and we're looking to do this on 1,000 patients to look at the feasibility of doing this, and then funneling patients in with potentially actionable mutations into either standard of care or clinical trials. So I think it has to be the way of the future that we're doing multiplex testing and using tissue wisely, and so that all patients get access to the best possible treatments.
I agree. Couldn't agree more. And then the next step will be making those trials available via telehealth. So if the mutation's found, we can treat a broad range of patients everywhere safely. So
absolutely.
Fantastic discussion. It's an exciting time to work in the lung cancer field. Who would have thought that 10 or 20 years ago?
Definitely not.
It is amazing. And I think some of our trainees listening probably just don't realise that the changes in our careers have been quite extraordinary, even where people didn't get treatment for advanced lung cancer universally not so long ago. So it is amazing and a lot of work to do, and it's all backed by science. So thank you so much for taking the time. It's been a great discussion, and look forward to having you both on again sometime soon.
Thanks, Craig. Enjoyed it. Thanks, Gilberto.
Thank you very much.
Bye, guys. It was a pleasure.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.